Thank you. We are running almost out of time. So one last question from, I think Vaidya has raised, whether there was.
Okay.
Right. So the next topic is intraoperative radiotherapy. Especially it is very topical and generating a lot of interest in various parts of the world during this pandemic. And it's a pleasure to invite Professor Jayant Vaidya, who needs no introduction to this forum at all, who has been the pioneer in this field, he's going to update us where do we stand with intraoperative radiotherapy. Over to you, Prof.
Thank you very much. I'm going to share my screen, and I think, let me know if it's all okay. Yeah, is it all right?
Yeah, it looks good.
Yeah, it's fine.
Thank you very much. So this is the photograph of the writing committee of the latest papers on the Target A trial. And I must acknowledge all the participants, patients, and investigators from every center who participated in these trials, the steering committees, and the authors of the papers. This is my potential conflict of interest of grant from NIHR and some honoraria from Carl Zeiss. So as you can see, this is a stamp of Tata Memorial Hospital in India. Where it started out for me is I told as the senior resident in Tata Hospital that patients from all over the country, you have breast cancer, can they stay in Bombay for 6 weeks, as we called Mumbai that time? And if they can, we could preserve the breast. If not, they had to have a mastectomy, because the standard of care, as is there many times now as well, is to give whole breast radiotherapy. And that was not easy for people in India. It's not easy for people all around the world as well. And so I thought it was only related to India, but it's not. So at the same time, I was doing this whole organ analysis of mastectomy specimens, in which I found something new, is that cancers were present all over the breast. And this was at odds with the recurrence risk. The recurrence risk was mainly around the cancer, original cancer. So that's when I thought that it would be sensible to target radiotherapy just to the tumor bed. And after I published this, I came and met Professor Baum and Professor Tobias, and there was an industry who we developed a machine to try and see if we can test this hypothesis using a new device and a new technique. So there you can see the applicator sphere going with the tumor bed. Sorry. This is the operation theater, and that's the specimen excised. That's the X-ray of the specimen. And you can see this, the tumor is excised and you're taking a purse string suture. It's actually a very straightforward method. Once the purse string is taken, you insert this applicator inside. And I'll show you this in some detail because many of the audience are surgeons. So it's actually, you need to take a suture just under the dermis into the breast tissue. And once you've taken the suture, you should test whether when you tie this, the dermis should not be in touch with the applicator. So as you can see here, the green line here is the tumor bed. This is what you want to oppose to the applicator surface. It's only the applicator sphere which gives radiation. And this is the purse string where you should take. You should not take it so deep because then you would miss out on this tumor bed. And once you've tied it, you find that the applicator sphere opposes to the tumor bed, and the distance to the dermis skin should be 8 to 10 millimeters. If it comes too close, it burns the skin. But this is not difficult to achieve at all in almost every situation. So once you have excised the cancer, this is what you would do. And take the purse string. And you've been doing it through COVID times. And this is how it looks in the operation theater once you've done it. That's how it looks on the table. And we cover it with lead shields so that people can stay in the operation theater if they want to. The anesthetist stays in, the physics team stays in behind a lead shield, and it works well. Now, as you know, most work of these early breast cancers is done by the surgeon. This was a 25 millimeter grade 2 and grade 3 cancer, excised, it's 0 out of 2 nodes. And she was given intraoperative radiotherapy, and that is the only treatment that she needed. So this technique was developed in UCL Middlesex Hospital between 96 and 98. Radiotherapy is delivered immediately after lumpectomy and is focused to the tumor bed, so targeting the tissues at the highest risk. And it avoids normal tissues like lung and the heart who are nearby, and is based on the principle of precision and immediacy. We have different size applicators for different size tumor beds, from 1.5 centimeters to 5 centimeter applicators, depending on the size of the tumor bed, which can then made to oppose the applicator surface. So this surgical technique was published in early 2000s, and the first 25 patient results. And then we started the randomized trial, asking the crucial question, can risk-adapted single-dose intraoperative radiotherapy substitute and effectively substitute the usual standard postoperative whole breast radiotherapy? As you may know, the trial started in March 2000, and the last patient was recruited in July 2012. So 2,298 patients due to have a lumpectomy. They had to be more than 25 years old with unifocal breast cancer. There were no other, particularly, it was invasive duct carcinoma, and preferably less than 3.5 centimeters. We did not need an MRI. MRI was done only about 5.6% of patients. The whole trial was done in about 10 countries. The random allocation was to have lumpectomy and single-dose radiotherapy under the same anesthetic. Postoperatively, if we found certain risk factors, and in those days, we used to do cytology to go ahead with an operation. So unexpected lobular cancers or positive margins would mean that we would like to give whole breast radiotherapy in addition. And the control arm received postoperative radiotherapy. The first results were published in 2010, and then again, first survival results were published in 2013. While waiting for the longer-term results, the many obvious benefits of IORT as a single dose were explored. And these were several obvious findings were confirmed in proper studies. Cosmetic outcome is superior with IORT. Quality of life is superior with IORT. These were studies in Germany and in Australia. Patients have less pain and have less breast and arm symptoms. These were studies in Denmark and in Germany. And these were studies which were very interesting, is that patients, when they were given the option that IORT may increase the risk by large amounts, even 10%, they still preferred it. In reality, it doesn't increase the risk, as you will see soon. And these were both in US and Australia. And this is a point which we keep talking about naively, that it would be good, but it may be paradoxically have an opposite effect, is that IORT is cost saving. So in US, Michael Alvarado showed that if it was implemented and used for suitable patients, it would reduce the healthcare burden by $1.4 billion over 5 years. In the UK, similar study, but the cost of giving external beam radiotherapy is lower. So the radiotherapy would save less amount of money, but still about $9 million, 9 million pounds. It obviously reduces the distance that patient has to travel and reduces the patient journey. And this study by Mr. Nathan Coombs and colleagues showed how patients, this is a map of UK, and you may not realize it. The red circle is 13-mile radius, so 26-mile diameter around the center of radiotherapy. So anything more than that, patients would need to travel more than 13 miles to get to their radiotherapy center every day for as long as the course of radiotherapy is. And you can see how much part of even the UK is far away from radiotherapy center. So by reducing those travel miles, which typically about 750 miles of travel, 30 hours of carbon dioxide, and a lot of carbon dioxide would be saved from getting into the atmosphere. This is an interesting part, is that biologically, it seems to make a difference. Now, all of us surgeons here would be quite scared with this finding that surgery and the fluid that is collected from the wound after surgery stimulates proliferation and invasiveness. And this was work done in Italy by Dr. Massaruth and Dr. Baldassare. But if we take the fluid taken from the wound after they have received intraoperative radiotherapy, it abrogates the stimulatory effect. And you can see this, that the amount of cells invaded is reduced. The top panel shows the cells moving around bathing in fluid from normal wound, and the bottom panel shows the moving around in the wound after IORT. So it seems to have an effect locally in the local microenvironment, which may actually spill over to distant sites as well. So back to the Target-A trial. Here I'm going to show you some long-term results of the Target-A trial. And as you know, breast cancer has a long natural history, so long-term results are important. And for this, you'll recognize that the first patient was randomized in March 2000, and the data lock was in July 2019. So we have really long-term data. And for completeness of this follow-up, we actually set the bar very high. We said that follow-up is to be considered complete, and we would not unblind the data until 95% patients had at least 5-year complete follow-up, and 90% patients had at least 10-year follow-up or was seen within the previous year. teams from all over the world who participated, helped in getting this data together, and the Surgical Interventional Trials Unit at UCL was really instrumental in making this happen. As the accrual was slow in the beginning and then picked up, that's how the completeness of trial is. These are the actual and expected follow-up data, as this is very close to each other and close to the two randomized arms as well. And as a consequence, these are trials of partial breast radiation compared with whole breast radiation for invasive breast cancer. And you can see target A has the largest amount of data, follow-up data. Each bar represents the number of patients in that many years of follow-up. For example, red bar here represents 5 years complete follow-up, and that is with target A, and that is with any other trial. So this was the randomization just to compare risk-adapted intraoperative radiotherapy versus whole breast radiotherapy. And this is important here to recognize that all factors, tumor and patient factors, matched equally. And importantly, there was no difference in age and BMI. And you'll come to this in the later part. These are important risk factors for deaths from other causes, such as other cancers and cardiovascular deaths. So the advantages are known. Surgery and radiotherapy was completed at the same time. There was less travel, better cosmetic outcome, less pain, fewer complications, less toxicity. But the patient is worried about the chance of living without the cancer coming back. And what are the results? So these are the results. At 5 years, you know that 94 patients will be alive without local recurrence in each arm of the trial. There was one more local recurrence, but one less death with target IORT. Many of these slides have this QR code. If you use your camera to look at this, normally the phone will take you to the URL. So they come up again and again. So in terms of long-term outcomes, this is local recurrence-free survival and invasive local recurrence-free survival. There was no difference between the two arms of the trial. Mastectomy-free survival, that is chance of breast preservation, and distant disease-free survival was no different between the two arms of the trial. Breast cancer mortality was not different between the trials, sorry. This is breast cancer mortality in a magnified form. And this was the very good result that showed that non-breast cancer mortality was significantly reduced with target IORT. And that led to a reduction in overall mortality, which was not statistically significant, but still remained, and the curves remained below that of EBRT in terms of mortality. So these are the results. If you want to have one slide for all the results of the targeted trial, they are here. 2,292 patients, median follow-up of 8.6 years. And this is really important. I will stress in a few seconds how these are not low-risk patients. And the difference at 5 years is 4.4 at 12 years. Difference at 12 years in terms of non-breast cancer mortality is 4.4%. If this was a difference found in any chemotherapy trials, you would suddenly find everybody adopting it. So in 2000, we had the first patient randomized. 2010 were the first results published in Lancet, and this is our conclusion on the front page, which remains valid today. And these are the 2020 results published in the BMJ. And it did get quite a bit of publicity all over the world. This was in the front page of the Times, and I realized later on that we shared the page with the new president. So important points to consider. If you are interested in using IORT in your patients, you can scan this one and answer a questionnaire, a small short questionnaire. The reduced mortality with target IORT is plausible because myocardial perfusion changes start appearing within 6 months of whole breast radiotherapy. This is particularly more in patients who are smokers. And patient who is 50-year-old, by the time she reaches 80, and this is true that when a large proportion of patients will reach the age of 80, a quarter of them will die from breast cancer. And this is a 6% increase compared to those who do not have whole breast radiotherapy. Now, whole breast radiotherapy would not increase breast cancer survival by 6%. So smokers, I don't think it's ethical to offer them whole breast radiotherapy for early breast cancer. What is important to recognize is target A population was a typical population in our Western breast clinics. 20% patients were grade 3, 22% were involved nodes, and 19% were either ER or PR negative. So They were not the ultra low risk patients at all. Compare that with the Prime 2 trial. Only 2% were grade 3. They were all node positive. Nobody was node positive. Nobody was ER negative. And what was the finding in Prime 2? There was a 10% recurrence rate at 10 years with 0.9% with whole breast radiotherapy. And despite this avoiding of radiotherapy, there wasn't any reduction in breast cancer deaths. And is that because the non-breast cancer deaths were reduced? Sorry, non-breast cancer deaths were reduced, but overall survival not reduced. So we should have seen a reduction in breast cancer deaths by that proportion. Was that nullified because increase in non-breast cancer deaths? We're yet to see the full publication. Whereas with Target, with good local control, there was a reduction in non-breast cancer deaths as well. As regards the fast forward trial, this is a medium risk population. There was scattered irradiation to the vital organs, and it is a backward step of giving radiotherapy to the whole breast. There was higher toxicity. A quarter of patients reported having hardened or firm breast, and breast induration was 19 times higher by physician assessment. And we don't have long-term data. And compare that with Target IORT, a very similar patient population, less toxicity and less trouble to the patient. And if you compare various types of partial breast radiation, and I think we should show patients these photographs before they make a decision about which type of partial breast radiation they can take. And you can see the detail about this table in a recent British Journal of Cancer publication. And so here there is a very detailed table of all types of radiotherapy. And well, I may be biased, but it looks like it will be a no-brainer for a patient to finish their radiotherapy during the operation itself. And it is being used around the world. So these are data from France, where they reported very similar results. And this is data from China, results similar in 2 arms of the trial. This is from St. Petersburg in Russia. They have now treated more than 1,000 patients. This is from a registry, a prospective database from 4 countries in Europe. And this is from France again, very similar data to the Target A trial. And in oncoplastic surgery, you can do the lumpectomy, give the radiotherapy, and then do good procedure so that you get good cosmetic outcome and good local control as well. And if you give it in addition to whole breast radiotherapy after neoadjuvant chemotherapy, this data, although prospectively collected but non-randomized data, suggested that there may be an improvement in survival as well. And that is going to be tested in the Target B trial. And Target B trial is currently recruiting. This is in patients who are younger than 45 and a very high risk, so they would be excluded from patients like Target A. Out of 1796 AIM, 1338 patients have already been recruited, and this is a trial of superiority of intraoperative radiotherapy boost compared with whole breast radiotherapy. Now, so this is the conclusion of the trial, and I have another 3 or 4 minutes to go. Target IORT during lumpectomy achieved comparable local outcome. It reduced non-breast cancer mortality, better quality of life, cosmetically superior, less pain, much more convenient to the patient, less travel time, and lower cost to the patient and the healthcare system. I believe eligible patients should be offered IORT as a one-stop option during the lumpectomy for breast cancer. NICE recommended it already in 2018 in centers that have the equipment and expertise. People around the world are using this, US. These are conferences where people have met. This is in Mannheim, and around the world, 45,000 patients have been treated with IORT in 38 countries in 260 centers. And these are all the centers around the world. What is important here is, coming last patient point, is this was a study published this month when consistently offered to all patients in the US, patients chose IORT over whole breast radiation or no radiation. And this is on the BASO website, which makes it very clear that today, with the GMC guidance, NICE guidance, and the law, it is wrong to not offer this to their patients. And I'll end with this patient point.
8 years ago, I was diagnosed with early stage breast cancer. I had it for 2 months only before I was cured. I had Target IORT at the same time as the operation to remove the cancer. I spent 1 night in hospital and I was back at work within days. No pain at any time, no complications, no scarring. I can't even tell where on my breast the surgery was. And no recurrence. 8 years. And that isn't just me being lucky. Studies show that my experience is similar to that of other women who've had target. I am so happy I was able to have this treatment.
So this is really, I would like to end with, this should be offered to every suitable patient. And in the UK, it is not just good clinical practice, because not offering it goes against GMC guidance, NICE guidance in centers that have the equipment, and with Montgomery law, it breaks the law. Thank you very much.
Thank you, Prof. As usual, a brilliant presentation. There is enough mature data to show the benefit of intraoperative radiotherapy. And what is the main obstacle or hindrance? Why are we not adopting it widely?
Cheaper. So it is, this has been said by not me. It was said in 2016 by the chief of the Red Journal, the main journal of radiotherapy. And to quote him, he said, intraoperative radiotherapy would be a very high quantum leap forward, depending on your perspective, or a very serious threat, because a normal radiation oncology, breast cancer forms a large amount of proportion of the practice of a routine radiation oncologist. And this, if the amount of money paid for this is not the same, and if it's paid by number of fractions, then people will have, whatever the reason, this is not the people want to treat patients. They want to give best for their patients. But when other factors start coming in, hospitals may make less money. I have never said this openly, but I've been told this by a radiation oncologist saying, oh, I may lose my job. And I don't believe they will lose their job, because there is a dearth of radiation oncologists. They are very much involved in the patient care. A fifth of patients will require whole breast radiotherapy. Because of this, more patients will be able to get breast conserving surgery rather than a mastectomy. So I don't think it will be it's only a perceived question, really. When we got cimetidine, the gastrectomies stopped. We didn't continue to do gastrectomies when we got cimetidine. We didn't do thoracoplasties when we got INH and rifampicin. We have a treatment which can avoid this, particularly in COVID times. And that is why 280 centers around the world are using it. It takes time to make change. NICE already said yes, but there is no patient pressure as much here in the UK as is in the US. US, there are 85 centers using it because they attract more patients. And I think this is going ahead. Now, NICE is also looking at it again. So I believe once it comes through, it will be used. And particularly in India, in Tata Hospital, for example, the median size of the tumor is 3 centimeters. And if there are 5,000 patients being treated in Tata Hospital, if the median size is 3 centimeters, 2,500 patients are less than 3 centimeters. And the paper will be coming out soon. There is no particular subgroup where it doesn't work. So once the tumor size and they're suitable for breast conserving surgery, you may need 25% patients whole breast radiotherapy afterwards instead of 20%. But it is something that we should have a high chance of avoiding back and forth trips to whole breast radiotherapy.
Thank you.
And probably
Jayant,
yeah. Yes, thank you.
Jayant, excellent talk. Have you sort of done any analysis? Because in Indian subset of patients, the tumor size is definitely shrinking down, but still, average tumor size across the country is a little different. And the lymph node metastasis pattern and younger population, less hormone receptor. So have you sort of seen what % of Indian population would actually fit into this? This is something which every surgeon love. I would love, and then we also placed an order to purchase this. The only criticism which everybody faces, the medical oncology and pathology, is you're already delivering a adjuvant treatment without the full information. I'm aware that a lot of factors can be predetermined, and if by chance you miss it, you can always count as a boost, and this is the best boost. No argument about that. How do you sort of overcome this? We already deliver the adjuvant without full information being available, like the margin status, and everybody doesn't do sentinel node. In India, the percentage of sentinel node is just 10%, and the final histopathology would change. So this is something which most of the radiation oncologists and pathologists, medical oncologists feel. So like, what is your take home? And then now with the fast forward coming, the suddenly, you know, like a lot of things, dynamics are changing. Where do you see it positions?
Okay. Well, firstly, before you do an operation, you don't have the final pathology either, do you? No. You know what I mean? While before we start doing the operation, we don't have the final pathology. We know as much as we know. And in terms of subgroup analyses, only problem will be if the margin becomes positive. And in the trial, about 8% patients of positive margins, about 9% patients needed whole breast radiotherapy because of that, and because of re-excision. So that is the main factor, really. The margin positivity is not known. But in every other respect, whether node positive or not, or whatever is not known, we didn't find node positivity or ER status or HER2 status as a predictor for poorer outcome with IORT at all. They were similar. About only 50 to 60% who were node positive ultimately received additional whole breast radiotherapy. Now, in terms of fast forward, it's really important to recognize that people who have pushed fast forward as standard of care, even before the main paper was published, were the same, and that fast forward had a median follow-up of 6 years, were very concerned that, that the follow-up was short, but then it was okay to push fast forward. Now, fast forward is not really 5 days. Fast forward requires 7 days of hospital visits for the planning, and in quarter of patients, they give a boost. So it is 15 days for those patients, okay? Secondly, it is a backward step to giving whole breast radiotherapy for all these patients when they may not need whole breast, and world is moving towards partial breast. And thirdly, they made it, when you read the paper carefully, you find that the breast induration is a quarter of patients. Now, we have not seen quarter of our patients coming back for follow-up complaining of breast hardness. I think that is quite a large proportion, and patients should be warned when they're trying to get this. It was pushed because of COVID. But if in centers where IORT was available, they didn't do fast forward. In Australia, for example, Professor Saunders told me very clearly, we're not doing fast forward, we're giving them IORT because it is almost all patients is finished in that during the surgery. So I can see the point you're saying, but in India, in terms of the numbers, I have not done the calculations, but I expect between 15 to 20% of patients presenting to the clinic, and probably half the patients who are having breast conserving surgery at least would be suitable for having IORT. And many times, this is one interesting point, when it was being adopted in Dammam, in Middle East, the surgeon, Maha Abdel Hamid, she presented data how in their center, only 10% patients were having breast conserving surgery. And when they started advertising about availability, people came to know about IORT as a possibility, many people started coming to her, and their rate of breast conservation, which was 10%, went up to 40%. Just because more patients are coming to them and they realize that, yes, they can preserve the breast. So it is a dynamic thing, and we must listen to the patients really, and patients will want this. And I'm very encouraged how worldwide people are trying to adopt it as much as possible. Yeah.
Jayant, just could you actually just tell us about your theater time? How much extra theater time would need? That's just allows one thing to add here.
It takes about 25 minutes. Typically, a patient takes 25 minutes of radiation, and you can probably add another 10 minutes to take the suture and position everything. So it's about 35 minutes or 40 minutes of extra theater time. So it is possible to do 2 or 3 cases, even taking the time change between the cases in a day. So it's not too much of a problem, but it does give quite a bit of satisfaction. And I had patients coming from around the world, around the country now, and they go back and they don't have to go back. And there's many times they have to travel 2 hours to the radiotherapy center, you know.
Thank you. And Jayant, can you just throw some light? And a lot of people ask, and it is perceived as very expensive, venture. And I'm sure there's a lot of cost analysis as to what happens. And then you have given already some ideas to, eventually it will save money for the healthcare system.
Yeah.
What is the situation regarding the acquisition of the equipment? Do people really necessarily need to buy it? How do people go about, going in this direction? Because, it is quite amazing that, we started here and then not many centers in the UK have managed to adopt it.
Yes. So what I feel is, yes, it is not cheaper. Yeah, so it is not expensive. Okay. So I'll put a link here, and people can fill this form in to tell me their names and email addresses so I can send detailed information. The machine is a fraction of the cost of a LINAC. LINAC needs to be replaced every 10 years. And there is a very good business case for having one LINAC. Many people have two LINACs, one LINAC and one IORT machine. It will actually make more money for the hospital as such. The cost of the equipment is about 300,000 pounds, or between 300 to 400,000 pounds. And I believe the company has many systems by which it can be loaned. And if you look at the cost, if you treat, by the time you reach 100 patients treated, 100 or 150 patients treated, you have recuperated the cost. So cost is a reverse argument. We used to say, oh, it is cheaper, so start using it. And strangely, it started causing people to back off because of that. But if the treatment is given, if the remuneration as per the value, so as what is happening in many parts of the world, it's value-based remuneration, not activity-based remuneration, then it will work out very well for the cost business as well.
Thank you.
And it is very easy to run. We used to have five cases to be done before we enter patients in trial. The technique is not difficult for any of the surgeons, breast surgeons who do normal breast surgery, and it is easily doable. You can do your when you're waiting for it. Yeah.
Thank you. I think we got a couple more minutes. If I could wrap it up, I think Vaidya has got one question. No.
Thanks for the brilliant presentation, Jayant. We have clearly understood that you have a big drive to drive this new technique forward. Now, honestly, what do you think is the barrier preventing adoption of this technique nationally in the UK as well as globally? Because for the fast forward trial to be adopted in the UK in the COVID pandemic took us a couple of weeks. So is it a barrier to the understanding of the whole tumor biology that people are not adopting? Or is it the cost or the difference in the culture?
Probably the last one. Here, the treatment is being done by surgeons, and that may be one factor. They have to get equipment. That is maybe the second factor. But as you're saying, there is obstacle to adoption around the world. Well, there probably is much less adoption obstacle. In Israel, there are 9 centers who are using this. US, there are 80, 85. Germany, there are 65. So it is being adopted all over the world, where patient power has much more effect on adoption. So it is other thing that has happened is the NICE guidance was rather ambiguous when they gave it in 2018. And when that improves, that may improve the adoption in the UK. And once clinicians have little more say in the matter of what is being done, and if people don't perceive it as a turf war, I think it will make a big difference. If it should not be perceived as a turf war, there are patients of the whole multidisciplinary team, and it doesn't matter whether they're treated in the operation theater or in the radiotherapy department. Once that is clear to everybody's mind, I think it will work out. The difference between fast forward adoption was it all happened in the radiotherapy department. The amount of fees for fast forward with IMRT is thrice that of normal radiotherapy. And it's same for 15 days versus 5 days. That's something to remember.
Professor Sirka?
I must congratulate once again, a fabulous talk as usual. The issue is, I think this would actually, if the real world evidence comes out to the way you are looking at, that would be the best choice for countries like India, where the distance from the center of radiation from the patient's home, you mentioned 30 miles, quite often it's 400 miles. So the patient needs to stay back at the hospital, at the town where the radiation has been given for months together. So that would really make a big difference. The second issue is large volume breast. I mean, large volume breast with the traditional radiation machines, it's a very difficult proposition in most of the government centers in India, and where I think IORT is going to make a big difference. So congratulations once again. And if things go the way we want it, I am sure that would be a big boost for Indian breast conservation therapy, because radiation remains the biggest block in implementing breast conservation therapy in India.
Thank you. Thank you very much. And I understand AIMS is about to get it. So I will start this. flow. Yeah.
Thank you, Prof. There is a lot of questions on the chat which we couldn't address fully. If you don't mind, if you could address them, that'll be great. Thank you so much.
Jayant, please, actually, there are a few questions that are quite
Yeah,
interesting.
can you just, we have few minutes, we can shorten the break. Dinesh, could you take some of the
I think
questions?
one burning question was regarding recurrent disease, because in St. Gallen, there was a big thing about re-radiation and re-white local excision after recurrence. So somebody has raised the question whether we can use the same for recurrent disease.
Yes, it has happened. We have done this. There is a patient series published. So patients who have had whole breast radiotherapy in the past and have recurrence in the same breast, they can have wide local plus intraoperative radiotherapy, particularly if it's invasive ductal carcinoma. That's one. Secondly, if patient gets recurrence in other quadrants after they have had recurrence in one area, then they can have IORT again, and that has been done. But of course, there's no randomized trial to test that, but it has been done. And we got long follow-up for those patients as well. Then the other question was, I
think there are multifocal tumors or tumor satellites. How do you deal with that?
Well, don't find them. I mean, don't do MRIs. But what I'm trying to say, yes, if there are multifocal cancers, we have not treated a patient with 2 cancers in the same breast, but I have treated patients with 2 simultaneous cancers found in 2 breasts. And biologically, I don't know whether it's too different from 2 different quadrants in the same patient. But in the trial, if patient had 2 cancers found on their mammogram, then they were not eligible in the trial. So, and that's not very common either way. So that is the good part.
There's a question about applicator that can't be disposable. No,
it's not disposable. Applicator is not disposable. It is sterilized like a routine instrument and goes back and comes back to the patient. So applicators last for quite a long time. So they're not a cost to the patient. No. And that is different from balloon, and balloon needs to be replaced every time, $5,000. That's why that's a good business model for people like Printer Inc. and Printer. But for applicators here, it's the one cost and it is reusable.
Thank you. I think that sums up the session. Thank you, Professor Sircar. Thank you, Professor Somshekhar, and all the speakers. Thank you so much.
Thank you.
Thank you. I think we'll take a break and we'll catch up at 12:30 then.
I hope Diptender can stay and Somshekhar, you can stay for the second half if you can manage. We'll take a little break, a comfort break, and then we'll be back.
Thank you. Thank you.
Cannot stay back. I have a meeting for the APSICON, and once again through you I invite you all to be part of the APSICON, which is happening in India. Hopefully, if the second peak is not lingering till August, towards the end of August. So do come over to India, and Rishi is the key person. You can talk to Rishi and decide your trip to India. Thank you very much for the opportunity, and I'm really blessed to have such wonderful friends. Thank you very much.
Thank you, Prof.
Thank you very much.
Thanks, Diptender. Okay, so
could we? I think we are in the break. I think you can have a cup of coffee and come back.
Yeah. See, I'll be keeping the delegates will stay online. I guess we just go on and
yeah.
We don't know.
And in the meantime, while we are working on the background, they're sending questions.